Good afternoon. This is Doug Farquhar with the National Conference of State Legislatures. Thank you for joining us for the National Conference of State Legislatures webinar, Disaster Response and Recovery, How Research Improves Preparedness, Response, and Recovery. Today's webinar is being hosted by NCSL, and for a list of upcoming webinars, please visit www.ncsl.org. My name is Doug Farquhar. I direct the Environmental Health Program, and I'll be your moderator today. Today's presenters will be sharing specific examples regarding disaster response and recovery, including research related to flood resilience in watershed communities and how water resources, food security, and energy system design can be implemented in a resource-constrained community. Before I begin, I want to mention that this webinar is being recorded, and registrants will be able to access a recording of the webinar and presentation slides on the NCSL website. Today, we are very honored to have a couple of very big names in the area of disaster resiliency. Dr. Aubrey Miller is the Senior Medical Advisor to the Director at the National Institute of Environmental Health Sciences. He is currently the Senior Medical Advisor and oversees legislative policy, strategic planning, and coordination of environmental health issues and activities among the U.S. federal agencies, Congress, academia, and other stakeholders. Our second speaker today is Dr. Craig Just, who is an Associate Professor of Civil and Environmental Engineering at the University of Iowa and the leader of the Flood Resiliency Team within the Iowa Watershed Approach Project. And with that, I'm going to ask Dr. Miller to begin. Dr. Miller, are you ready to go?
I am ready to go. Am I coming through?
You are coming through very clear.
Okay, great. And I'd like to thank NCSL for providing us this opportunity to talk to folks a little bit about the National Institutes of Health, and in particular our institute, the National Institute of Environmental Health Sciences at NIH, about doing disaster research and trying to understand the health impacts on communities throughout the United States and even globally with respect to these efforts and improving our abilities to understand these situations better and to be able to address these situations more quickly and more thoughtfully and more strategically with multiple partners in addressing these problems. But quickly, I just wanted to let folks know a little bit. The National Institute of Environmental Health Sciences is one of the 27 NIH institutes. We're the only one that's not located in the Bethesda campus in Washington, D.C. The institute's located in Research Triangle Park, North Carolina. And like other NIH institutes, we have intramural research. And in our case, our mission is to discover how environmental factors affects people's health and how to do something about those. We also have extramural research through grantees and researchers throughout the United States and throughout the world, and specific centers throughout the United States that focus on promoting environmental health across the country. We also have specialty programs that focus on worker training around hazardous materials and around Superfund research program that partners with CDC and EPA to try to understand hazardous waste sites, and a national toxicology program that we jointly partner with CDC, NIOSH, and the Food and Drug Administration to understand chemicals and other hazards and the toxicology associated with understanding what makes them risky and if products and these agents are hazardous to people. So just a little bit about that. I'm going to talk to you a little bit now about disasters and our NIH activities and how we kind of partner to try to promote this responsiveness to disasters across the country. And I'm starting with a slide that that was actually developed by our partners at the National Oceanic and Atmospheric Administration, which really just shows the increase trajectory of billion-dollar disaster events by type over the past years. And if you can see here how these have been CPI adjusted, and you can see here the number and costliness of these events has been increasing since 1980, relatively substantially. Like compared to in 2005, we had $214 billion, especially with Katrina, Rita, Dennis, and Wilma, if folks remember those hurricane events, compared to 2017 with Harvey, Irma, Maria, and the fires of over $300 billion. And this does not include the health costs. This is really straight off of the other kinds of outlays and expenditures that are more easily measured, but not the healthcare costs associated with these types of events. Additionally, I wanted to kind of use an event to talk a little bit about how NIH and our partners can come together in order to address some of the problems and disasters that we've had. And this is one that's not a natural hazard like a hurricane, but this was the Gulf oil spill, which occurred in April 2010, which killed 11 workers, 17 were injured on the platform, and there were 98 survivors, and that was just at the platform. This was the largest oil spill. If folks can see the Deepwater horizons at the bottom of that slide, these are a little bit funky looking, but it was over 4,900,000 gallons of oil that were released into the Gulf, affecting the entire Gulf coastal sea line pretty much. Folks might remember, people talk a lot about the Exxon Valdez, which was over 20 times smaller than the Deepwater horizon. One thing about the Deepwater horizon, and it was interesting as we began to explore it, that these oil spills happen all the time. And despite that, there had only been a few studies, only 8 studies really, that had looked at some of the health effects associated with these oil spills in 2010 when we got into the Deepwater horizon. With that said, it's really a statement about the fact that we're not getting good information with respect to these situations, including something like oil spills, which happen all the time, about what are the risks to our communities and to people involved, including the workers that may be involved with these types of situations. So with respect to the Gulf oil spill, there were actually over 130,000 people involved in the cleanup efforts. Some of them were professional workers, but many others were fishermen that were out of jobs that were now recruited to help clean up oil at sea, as well as you can see in the pictures here, multiple people involved in cleanup of beaches and wildlife and various other activities related to the cleanup work across the entire Gulf. So over 130,000 people were involved in just the cleanup efforts and the communities as well. So there was much needed in terms of guidance for workers and other types of information. What happened subsequently to the oil spill, and relatively rapidly, it happened in April, but by June, the National Academies held a meeting down in New Orleans and basically put it out there because that the Department of Health and Human Services recognized there was very limited information about what are the health implications associated with these oil spills. So the National Academies made some rapid recommendations and held a large meeting there in New Orleans, as I mentioned, and basically said long-term health research is needed on communities and workers, and to begin as soon as possible to not only consider the physical health impacts, but also the mental and social health impacts, to monitor vulnerable populations, to include all the external stakeholders, including the community groups, to be part of the process, and to develop data systems and ways to do research and information gathering in ways that it can be shared and leveraged going forward. So that was the quick ask of the agencies present, and the director of NIH, Dr. Francis Collins, leaned forward and helped to fund some research that we kicked off, and it's a nice model of programmatic pieces coming together to try to address this really important and large-scale disaster event. So one piece of it was, which here is listed as what we call intramural research, and this was research that we could do in-house. Within my institute, we have epidemiologists and researchers that and contracts that we could use to try to form studies of the workers and that were involved in the cleanup efforts. And this is a design study effort to try to look at workers across all the states and try to develop a cohort of our participants from the research community for a 10-year study, which is still ongoing, which we call the Gulf Study. Additionally, the worker training program kicked into gear and trained 130,000 workers, trying to use the best information possible and trying to provide information that we were learning about what are some of the risks and how to protect themselves while we were beginning to develop the study. I'll also mention that the National Toxicology Program, which partnered with other agencies and universities, began to look at, what was in the oil, what's washing up on the beaches, what do we understand about the dispersants that were being sprayed. Over 1 million gallons of dispersant were being sprayed across the Gulf. How do we look at that and evaluate that quickly and try to understand what might be the health risks with this mix of chemicals associated with the oil? And lastly, our extramural research, which is really our universities that NIH funds, were called into help, and we formed a consortia of universities, and I'll show you that in a slide in a minute. Additionally, we partnered with the Substance Abuse and Mental Health Services Administration to help look at the mental health effects of communities that were impacted by the oil and try to use funding and other resources with them and other federal partners to begin to answer these important questions. So in so doing, we tried to link some of this research together. I mentioned the Gulf Study, which was our study of the workers, and so we created a study of 33,000 workers involved in the cleanup, which is still going on, and that involved a robust testing, including medical testing and questionnaires and repeat follow-ups of those workers, and that's still going. Additionally, we formed a consortia with 4 academic centers, one at University of Florida, one at Tulane, one at Louisiana State University, and the other at University of Texas Medical Branch at Galveston. But they also joined with 45 community organizations, which is really important that they connected with the community, and the request was for the research was that they develop programs to help answer questions important to communities across these impacted areas, to look at things like seafood or resiliency or women and children health issues, and make sure that the communities are engaged, and other types of studies which would answer questions of concern to those particular communities, and to involve them from the get-go and create a network for both of these activities to work together and across the Gulf to connect the dots, so to speak. So here's an example of one of the community-engaged research efforts, and this was at the University of Florida, and they call it the Healthy Gulf Health Communities effort. And one of the questions that the community was really concerned about was the safety of seafood. Now, the Food and Drug Administration and others had been saying the seafood was safe, but a number of communities quickly identified that they ate different seafood that the federal agencies were talking about, and they also ate seafood in much greater amounts than some of the federal agencies were talking about that people along the Gulf Coast were eating. So there wasn't entirely a lot of faith in some of the federal discussions, and so University of Florida partnered with the Gulf Coast communities and the fishermen to go out and catch the seafood that people were interested in and interested in understanding further. And working together, they were actually able to look at the seafood together and actually establish that in fact it was safe for them, and further supporting the federal positions. So let's talk a little bit about trying to do research and the difficulty. And as I mentioned, there was only 8 studies on Gulf oil, on oil spills prior, and this has to do with the fact that doing research or data collection to help us answer a lot of these important questions is not routinely done. And I don't think people really understand that our federal system is really not set up well to collect rapid data collection and research in response to these events. And so here's a listing of events, whether it's Katrina, there's the oil spill, SARS, the World Trade Center, the Flint, Michigan lead contamination, the Zika, there's the California burning, Ebola, etc. I've worked on all of these, and the system is not well set up for states or locals or even at the federal level for us to collect good scientific information in a strategically sound way to be able to address these events. And it's always very difficult as the ICS and federal response framework systems really do not do this well. So the part of the issue is really the need for time-critical research. So this slide here that talks about some of the things, us coming at it from an environmental health standpoint in respect to these disasters, that we always try to answer a question is it safe? Is the environment safe for our communities? What are the physical and mental health impacts that we need to understand? What are maybe if we're going to be treating people that may have been exposed, what's the safe and efficacious medical treatments, and what should we be using? So if we understand what they're being exposed to, how do we best treat them in the hospital? What are the risks of these exposures, not just in the short term? As you can see here in the picture, there's a flood going on there. You know, what's the long-term exposure to the parks and playgrounds? There's also a picture there showing of the anthrax exposures there in Washington. That was a picture of me and my colleague on top of the Hart Senate office building. How do we decontaminate and clean these things up? What are the risk factors for recovery and resiliency in the long term? And how do we think about vulnerable populations? What's the risk to pregnant mothers, to children, to the elderly, or those with pre-existing conditions? What about communities with higher exposures to start with? They may be living next to factories or Superfund sites or other issues there. They have ongoing or high exposures. Additionally, and as I was mentioning, the research is not typically done, and these are some of the reasons why the research is typically delayed or missed. One is, I said, there's no formal way to activate or coordinate research across the country. We have difficulty funding it. There's no FEMA funding for this. There's slow reviews of what we have to do in terms of human health research. We need IRB, or institutional review boards, to make sure it's ethical and sound for community research, and that can typically take many, many months to get those reviews done. Lack of ready-to-go research tools and protocols. There's lack of trained researchers to get out quickly. Lack of inclusion of community stakeholders. If you don't have a platform to engage the community, it's very hard to say, we're going to come here and start doing research. And so here on the right is a box. You can see, and some of these things that lost opportunities is pretty much the routine. We don't often get out into the field. The H1N1 flu virus back in 2010 was one where we gave out a medication across the United States, but we could not get information back if that medication was safe or effective for the people using it. The department had no way to collect that information, and all sorts of other problems associated with trying to get that information back. As I mentioned, the oil spill, it took us 9 months to get that research going for the Gulf study, to start getting the worker information. That's a huge amount of time lost to start getting into the field, and people were leaving and gone, and a lot of the exposures had already changed. Hurricane Sandy was 11 months to get in the field, and the Zika response was another 4 months to get in the field. So as I said, these issues about are not just the acute response, but it's also this long tail with respect to disasters that we don't do a very good job of addressing. This continuum of information needs is really like an iceberg. The tip of the iceberg is really the response, but this recovery phase and understanding these long-term aspects, both in terms of the physical health and mental health, is really the big part of the iceberg that's underneath the water that we have a hard time addressing with our current system. And also, all of that should be feeding back to our future preparedness to make us better, smarter, and more effective. So here you can see there's a timeline for disaster response. The way you hear the presidential declaration goes on, it's really that middle arrow is the presidential declaration there, that disaster box, and that's what really our whole system does the best, which is getting in and cleaning up and doing the quick life-saving activities. But the longer-term recovery and the information that feeds back into future preparedness is typically missing. So in response to this, we've developed a program that it was in response to calls to action that have been coming out by multiple groups. I won't spend much time on that, but and in terms of those calls to action, we've developed a program to really try to begin to improve disaster research response across NIH, but in partnership with many other agencies. And here in this slide I'm showing you, it was recently a report came out in March 2019 about science during crisis, which was the American Academy of Arts and Sciences, calling for this across the earth sciences community and health communities. We've also had additional meetings with the national academies and others calling really a call to arms across the United States to develop opportunities and ways in which we can further our research capacity and capabilities. So with that, we developed the NIH Disaster Research Response Program in 2013 and have been working on trying to further and make things better, faster, smarter for researchers to get out into the field and begin to collect data. Some involve the ability to have tools and protocols ready to go for researchers, faster processes, including IRBs and communities and funding streams to help support this. We've now created networks, including new relationships with Canada and Japan to further opportunities both in the United States and globally to share ideas and programs and resources. And we've been having training workshops across the United States that we started in 2014 in Los Angeles. And these workshops involve not only the academic and research communities, but emergency management, public health, folks from hospitals, industry, communities that would be impacted or have been impacted. And we've been using different types of scenarios and situations to try to train and talk about the issues about collecting data and information in response to these situations, so we'd be better able to address these problems. So we've, as part of this, we've also have created a repository of tools and resources that we have available at NIH, and in our partnership with the National Library of Medicine, we have a website where a lot of these resources and tools are readily available to everyone. That it's open access, and folks can come and use these resources and tools and training materials and information from our training exercises to try to improve their ability to respond to situations, and including we provide technical assistance when something happens, and we get on the horn and try to help folks get out there in the field, and I'll give you some examples in just a minute. And one other thing that we developed that's being picked up and utilized by researchers across the country is a protocol. And so for researchers to get out into the field, they need to have an approved protocol to collect information about health impacts from people, and they have to have an IRB, what's called an IRB approved protocol. So working at NIH, we developed the first essentially a pre-approved protocol that could be used and modified quickly when a disaster happens, and then modified quickly to that specific situation. So if I wanted to do, let's say I was worried about floods and some chemicals that were being released, and I was worried about skin and respiratory and mental health, I would just take out those modules and modify the protocol quickly, and then we would send it in to our IRB for rapid review. A number of other grantees and academic centers have picked that up and have also created their own protocols as well. So I'm going to talk to you quickly about in 2015 we did an exercise in Houston that was focused on a hurricane that would hit Houston, and brought everybody together and had this exercise and talked about developing these tools and protocols, and which they, after that one-day exercise, they kept on working. And in 2017, when Hurricane Harvey actually hit Houston, as you can see in the picture here, folks came together and they leveraged conversations from that workshop. The academic partners came together not only from around Houston, but here you can see a slide on Harvey research efforts, and they got out within 14 days working together across Texas institutions, but they also partnered with institutions across the United States, as far as from North Carolina, New York, and Mount Sinai, including folks from Oregon State, and they partnered with Houston and Harris County and Texas health departments to do testing around schools and playgrounds, to evaluate community impacts and health to differing populations, and to work on mapping along with the health department of where problems in areas were. And they leveraged all these tools together and worked with the communities to do this. So this was a really great example of the model and what we were trying to achieve by coming together with this. And so subsequently, in this last year, we had another scenario that we worked with University of Arizona in Tucson and brought together people all across Tucson area, like I mentioned before, from differing backgrounds, to this time talk about a train derailment and the chemical exposures that could happen in association with the train derailment, using one that actually did happen in South Carolina a few years back that injured a number of people. And we said, well, if this was to happen in Tucson, how would we work together across all of these domains and collect not only the population information about the community, but also the hospital information, and try to work through that. So that was the most recent one we had. And lastly, we're working on a number of other issues. Let me just lastly mention about the IRB issue that we did in Tucson, because this is really important, because trying to get the IRBs and the research boards to try to review these things quickly is really important. So we've been advancing this, and in the Tucson in the Tucson discussion, we brought their IRB, and we had what's called mock IRB events, and we said, okay, here's the protocols for this train derailment. How can you review this quickly and take a look at this and come together and let's work through this together with their IRB and see how we can get these protocols approved. So we did it, and ran a whole mock IRB, and we continue to develop guidance and tools and protocols for IRBs. We're now starting to work with CDC and working with their groups and trying to develop them there and try to get this out and continue to facilitate and foster this going forward. So these issues keep happening. Where other crises around the country, whether it's acute disasters or disasters now like the drinking water contamination that's due to the PFAS chemicals happening across the country, I think these models and the importance of this program is incredibly vital, and working with our academic partners and universities across the United States can bring a lot to bear on the situations in addressing our human health concerns going forward. And I don't know if we're going to do questions now or wait till after we're all done.
Thank you very much, Dr. Miller. Why don't we hold off questions until the end? We have a few that did pop in our chat box, but we'll share that at the end. Right now, I'd like to turn it over to Dr. Craig Just, who is heading up the flood resiliency team within the Iowa Watershed Approach Project. Dr. Just, are you ready to move?
I am ready to move. Thanks so much for having me, and I also thank the NCSL for organizing, and I appreciate everyone who has joined in on the webinar. As mentioned, I'm Craig Just. I'm a professor of civil and environmental engineering at the University of Iowa. One thing here on this title slide is the URL to our Iowa Watershed Approach project. You can also Google that if you like and browse that perhaps even while you're listening into my talk now. We work really closely in the Iowa Watershed Approach with the Iowa Flood Center, which is one of the country's only state-funded flood centers. Flood centers has been around for 10 years. And also our larger research institution that I work under is IHR, Hydroscience and Engineering. And trying to get a slide to move. There it goes. So our Iowa Watershed Approach project was funded through the National Disaster Resilience Competition. We've got about a year and a half to 2 years, give or take, left in that. It was funded through the U.S. Department of Housing and Urban Development in collaboration with the Rockefeller Foundation. The funding pool for that particular competition was $1 billion. A lot of it was leftover Superstorm Sandy allocations, and then the Rockefeller Foundation pitched in half of the funds as well. Out of 14 applicants, Iowa received a very large award. We got $97 million to implement our Iowa Watershed Approach concept. The funding is actually administered through the Iowa Economic Development Authority, but the University of Iowa wrote most of the proposal and then also has funds on hand to do what I do as part of this, to lead this concept of a flood resilience team and some flood resilience programming that we've done all along the way. And as I mentioned, this Iowa Watershed Approach program is developed. If you ever see IFC, that's the Iowa Flood Center. And we too, as mentioned by Dr. Miller, many partners from all across the state involved. You can see in the graphic there the 8 major watersheds that we work in all across the state. And then we've got 3 communities, Dubuque, Coralville, and Storm Lake, that also receive some special funding and attention as part of this program. You might ask, why Iowa with respect to flooding? We've had almost 1,000 presidential disaster declarations in the last 30 years, resulting in about $13.5 billion in direct property loss and about $4.1 billion of direct crop loss. So around here we like to say the cost of doing nothing is not zero with respects to dealing with our floods here in Iowa. If you if you become a kind of a member, I would guess you could call it, of the IWA program, one of the first things you need to do is form a WMA, or a Watershed Management Authority. We've got some legal language in the State Code of Iowa under Chapter 28E to form a WMA. It's not very authoritative. It can't levy taxes. It can't condemn land. And so we had to emphasize very clearly early on that this is a voluntary program. This isn't some sort of a governing entity that can come in and take private land away and put in ponds or dams or whatever. That was a big component of this going out early on. Then we have to develop a hydrologic assessment and watershed plan. I didn't move the slide there. We have to develop a hydrologic assessment and watershed plan. Then we deploy some monitoring equipment. In Iowa, we have a very large stream sensor network that the Iowa Flood Center administers with over 250 sensors out and about. Really critical to this project are project coordinators in each watershed that we're working in to really go around and make all those partnerships happen, talk to landowners, because in the end we are putting practices on the land as part of this project. Roughly $40 million of the funds are spent for projects in rural landscapes and roughly $40 million in those three communities that I highlighted before. In the end, our overall goal is to reduce the magnitude of downstream flooding and improve water quality. And then since the only way we can, physically assess the benefits of this is wait for another big storm to come and then measure the difference in flood extent and flood damages. Since we don't want to, wait around for that, and hopefully it just doesn't come at all, we then use these very sophisticated computer modeling models or computer modeling programs that we put together to assess these benefits in the virtual domain, such that we can make sure that what we're doing is valuable. The program is focused on Iowa's flood hydrology and water quality, and with a few more specifics here on what we do in each watershed with respect to the hydrologic assessment, which is kind of that blue color in the circle shown there, the 5 major elements that we're tackling in this particular program. We measure the hydrology, the geology, and the soil types, topography, land use, and then we instrument things as said. BMPs, so those are best management practices. We did a statewide BMP mapping project, so we would know all the existing BMPs throughout the state of Iowa. And then we have some different computer modeling activities that can then help us understand the potential best management practices that might be available to us. Then, as I mentioned, we build that model, and then we can do various watershed scenarios. We can say, well, what if we go to 100% tall grass prairie in Iowa instead of row crops? What if we put in distributed ponds and wetlands throughout the watershed to capture stormwater and protect our critical infrastructure? We can run those scenarios and then make some informed choices as a watershed community on what we want to do going forward. When it does come time to build something, to put a hard practice in the ground, the project offers a landowner a 90% cost share, and the program to date has over 500 projects that have been cited and or under design. Much like Dr. Miller was referring to, this project is very focused on socially vulnerable communities. In fact, since the funding comes from housing and urban development, over 50% of the funds must be expended to the benefit of low to moderate income populations. And so we've got a fierce focus on that. And I will say as well that HUD also, we actually have a new HUD-funded research grant on our campus now to kind of even more refine the notion of low to moderate income as being the primary indicator for folks who are vulnerable. And Dr. Miller was mentioning other vulnerabilities, like you could be elderly, maybe you need to, you're disabled, maybe there's some other attributes too in the context of floods that are very important. Maybe you don't have a vehicle or access to adequate transportation. And so looking for a variety of hazards, the research is pointing us to better define the concepts of vulnerability and those basic attributes and customize those and match them specifically to the hazards of choice that we're looking at. One of the things we've seen around Iowa is that communities that flood repetitively lack resilience, and there's also this concept of a wet side and a dry side. What you see in the middle in the background of in the background image is a HESCO barrier that went right through a community in Cedar Rapids, Iowa, during one of their recent floods. And one side is wet and one side is dry. And, you know, a community decision was made to put that barrier there to leave some behind and then protect others. And so we know that wet side is typically less valuable, typically has low to moderate income populations living there. They are underrepresented when it comes to dialoguing and decision making. And many times they also are just vulnerable in water and food system support as well. And as we were evaluating various frameworks to look at to do our flood resilience programming in this project, came across a quote from a plan that was done by the city of Boulder that says, lower income people are among the least able to recover, yet they are often central to the economy and culture of a community. And so as we're going out doing our flood resilience work, we want to make sure we're reminding the locals that we want to make sure we're benefiting everyone in these communities, not just those who are affluent and have a strong voice in local governance. The flood resilience program, in a nutshell, we've got some goals. We seek to measure, visualize, and communicate flood resilience resources. We've worked very hard to enhance flood resilience content in formal watershed plans. And then we also look to improve social resources for flood resilience. I realize now one of the things I didn't show in this graphic a couple slides ago. Let me go back just briefly. These typical watershed plans that we've been doing here in Iowa didn't have a flood focus much at all. They're very much water quality oriented. They look more to EPA guidance on what's called a 9-element plan, sediment control, water quality aspects. And so one thing we found out is that the planners didn't really know how to put these flood elements into those more traditional watershed plans. We also then, as I mentioned, have these resilience action plans. And then the two other elements over there in that graphic, disaster recovery plans and hazard mitigation plans, those are required under the Stafford Act. And typically they're done at county levels, or maybe multiple counties come together to do that plan. But in a watershed context for flood mitigation, for flood disaster recovery plans, those should be done in the context of watershed communities. That was another thing that was very foreign to the folks in our state and in our counties, and then also foreign to FEMA as well, because in the end, FEMA has to, these plans have to align with FEMA objectives, otherwise you're not going to be compliant with the Stafford Act. And so we've had to work with FEMA all the way such that then these final watershed plans that contain these hazard mitigation planning elements then align with FEMA's objectives, so then you can apply for mitigation assistance appropriately. Additionally, our flood resilience team has some products for interactive flood damage estimations. You can go online and see those resources if you'd like. And then we have an interactive social vulnerability and flood risk platform that you can browse as well. I'll highlight today some products that are under development. Watershed scale flood hazard mitigation assistance applications. We're very interested in doing some of those. Really has to change the mentality for the way HUD and FEMA and other federal agencies look at hazard mitigation funding applications. I'll also briefly tell you a little bit about some of the town scale flood resilience action plans that we've been working on. And then this concept of coordinated care communities and how I feel that will, the research that we're doing there and some of the implementation, I think could make a big difference in the lives of folks who are socially vulnerable and at high flood risk. One of the things I think it's very important for folks on the webinar to understand is that if you do a hazard mitigation application, or if you do get a community development community development block grant funding from HUD, typically those dollars have to be spent in the census block that's being impacted. That's why a lot of our flood mitigation practices might be elevating a home in place, right? Putting a taller basement or putting a home up on stilts, meaning you spent the money directly in the census block that's being impacted. That can get you so far, that's fine, but we're recognizing here that, well, what if you spent those dollars away from the impacted area, upstream, in these watersheds? In this particular example, what if we put in a bunch of flood control ponds on private land up in the watershed, such that when the rains come, the water can be stored there to protect then any sort of downtown or any sort of downstream town or other area of high dollar value, and that's what we're demonstrating here, this notion of watershed scale flood hazard mitigation assistance applications, where we do the benefit cost analysis of a scenario like this, where you're spending money upstream to protect assets downstream. Again, a brand new thing for folks like FEMA to consider, but we're working very diligently with them to make sure that these things can be possible in the future. The other thing I want to highlight is just the increasing availability of things like resilience toolkits. Here's one that's a regional one put out by EPA. And this particular one has these resilience lenses that they want to help inform your planning processes. And this one in particular talks about social equity really, really well. And I encourage all of your planning efforts in this regard to use a tool like this. Another tool that we've used is the one that's been put out by the Rockefeller Foundation as part of the 100 Resilient Cities program. But we realize that here in Iowa, some of the cities we're dealing with are, 5,000 people or less. Some are in the hundreds, actually. And so a tool like this that's targeting major cities needs to be right-sized a little bit. So we've done some activities like that to make the planning processes that have been promulgated here in these sorts of resources right-sized for a rural case like Iowa. We went to Vinton, for example, Vinton, Iowa, 5,000 folks, and did some town-scale flood resilience action plans. That means holding some meetings in town, getting together. Many times you have to incentivize getting people who are particularly vulnerable to come. In this case, we offered $25 grocery store cards so that then folks would have additional incentive to come, because we wanted them to come to a series of 3 meetings. It took quite a bit of their time to do that, and that needs to be incentivized. This particular plan, and you can go online and look at Flood Resilient Vinton, we really emphasized the capture of flood stories. We found that people wanted to be heard and then also wanted some actions to take place, and so we tried to create a platform where those stories could be heard and retold again. The National Academy of Sciences has an extreme event game that has a flood module, and I just put it up here for folks and encourage you to use it. It worked out really well for us. We used it in stakeholder groups that involved sheriffs and emergency management directors and so on and so forth, but then also just for residents in a small town. And if you want any more information on how we did that, please be in touch. Coordinated care communities is something that I think is going to be a really powerful thing going forward. In Lynn County, Iowa, where Cedar Rapids is located, they have a coordinated care community. It essentially is an electronic referral service for the socially vulnerable who might be bouncing around from agency to agency or nonprofit to nonprofit just to meet their chronic needs. But then when a flood comes along, they've got this new acute trauma that they're trying to deal with. And so we want this coordinated care community to be aware of those in our midst who have this flood risk or who have recently flooded themselves, such that then they can get the care they need to move forward beyond that acute stressor, much like Dr. Miller mentioned early on. And then, since we are focused on state legislatures, I do want to let you know that we love working with other states here in Iowa. We had a whole group from North Carolina come. You might be aware that they just passed a $258 million disaster relief effort in that state. And they cited the Iowa Flood Center and the Iowa Watershed Approach essentially as one of the kind of governing principles on how they're going to spend those dollars. Their Office of Recovery and Resiliency will hire as many as 24 resilience experts to work with these regional resilience planning activities, particularly with respect to flooding and particularly in this watershed context. And then last but not least, we love this quote from the governor from South Carolina who said, currently there's only one state that has taken the step that I hope our state will take to seriously address this floodwater problem that we must tackle. That state is Iowa. And I'm tooting my own horn here, or at least tooting the horn of the Iowa Flood Center, just because I want to invite you all to be in touch. If there's something that I've highlighted on today that you find valuable, please be in touch. We love to work with you, and we love to spread the gospel, so to speak. And that's what I've got. And so you can be in touch with me or folks from the Iowa Flood Center if you've got more questions beyond the ones that I think we'll answer right now. Thanks so much.
Thank you very much, Dr. Jess. That was very informative presentation. The first question that's come in somewhat goes back to what you were discussing there. It comes to the point of state legislatures being second responders. They're not the first responders to a disaster, and they're not the third responders where when the federal government comes in and provides resources. They're the second responders. And this question goes to both of our presenters. What can states do to mitigate some of these issues, some of the disasters that come across? How can they lessen the impact of disasters?
So this is Aubrey, and you know, again, all disasters are really local, right? So it's understanding the resources and assets, and thinking about how to coordinate and identify those areas and gaps, and trying to resource more creatively. So one that I tried to emphasize to a degree is that the academic partners and universities and others have not typically been at the table, so that's a huge resource in many communities. That is kind of an untapped resource. We've shown a lot through our program of how this community can play a vital role in trying to help and support, and not only locally but also the network from other locations, helping and assisting and resourcing. So I think the state legislatures could, think about and coordinate and support empowering some of their universities and others in ways to be able to contribute. And I think there's a huge amount of interest across multiple stakeholders, as Dr. Just said, of trying to contribute, but it's also trying to create the platform to allow them to do so. Because I know even when we started in on our project, we had a huge number of folks saying, well, we want to contribute, but we just don't know where to begin. So I think it's helpful if the legislative folks can try to think about how do they create and bring folks together, or create that platform and allow these other entities and other groups to be able to come and figure out ways that they can contribute their resources and skills and expertise to not only planning but responding and even the longer term recovery aspects. I'll turn it over to my colleague.
Yeah, in addition to those things, well, first of all, a lot of local mitigation happens. There's a lot of, I don't know what you want to call it, novice flood control activities going out there. There's quite a few folks with bulldozers that can move some things around for some of these distributed storage purposes. We don't encourage that, but there's lots of evidence here in Iowa of things that have been going on since the 30s, in fact, with respect to conservation that then gives you, and built practices that gives you flood storage and other benefits. The other thing I think is critically important, especially if you're dealing with these rural populations or rural towns that are struggling, kind of like, financially struggling in rural Iowa, for example, is that anytime there's any federal mitigation dollars available, say you have a great application, maybe using this watershed approach like I've described, you still need to have money for a local match, and that's many times 25% of the overall project expense or the project cost. And these small towns don't have that, and so the state legislatures need to they need to have a pool of money there available to be used as the local match for these federal dollars that folks are going to be seeking. And in fact, North Carolina did just that. A pretty large fraction of that $258 million is a set aside then that can be local state match for any federal dollars that might come in. So I think that's important to do as a state.
Thank you very much, Craig. That is critically important. I have a question here that goes for Dr. Miller. Will workers who, as well as those who reclaimed cars from the hard rock collapse in New Orleans, will those be studied for respiratory disease?
Um, from which
Is that
collapse?
a little
I
bit
didn't
too
quite.
specific?
Well, I can give you a little, yeah, so the workers are exactly one of the groups that are not typically studied often. One example where workers were studied and showing the incredible importance of studying workers was the World Trade Center. So in that case, after much pressure, Congress allocated some funds to actually include the workers in studies, which showed a large group of the response workers. There were over 27,000 workers involved in the response. Almost a third of them had significant respiratory disease associated with that, and mental health disease associated with that. So I think it really highlights the incredible importance of including workers in studies and data collection as part of all of these events to make sure that that we take the appropriate protections, improve training, improve protective equipment in order to better ensure the safety and health of workers and be able to better advise them. So it's incredibly valuable. Now, some of the work that we've been working in the past several years have been really focused on workers and communities in trying to understand their exposures and risks and making sure that we translate that into worker training and protection. And that's why I use the example of the oil spill. But many others, especially a lot of the smaller situations that have been and continue to occur, there's very limited activity going on with understanding the workers' exposures and risks. So I would put that in a category of must-do data collection and research that we need to do to ensure that we protect our workers that are response workers, but also a wide range of workers that are coming to the table, including volunteer workers and others that may be cleaning up homes and out there mucking about and getting differing types of exposures and risks.
Okay. I want to say thank you. We do have some more questions that I'm going to have to privately forward it on to our speakers to get them answered. But at this time, we are running out of time to have any more questions. At this point, I'd like to thank both of our presenters today for giving us their time to speak on this important issue. And I want to give a thanks to our attendees for participating in today's webinar. As a reminder, a recording of today's webinar and the presentation slides will be made available within 5 business days on the ncsl.org website. If you'd like to discover where that is on the website, please feel free to send me an email and I will be able to send you a link directly to the website where you can receive the copy of this webinar. Also, as soon as the webinar ends, there will be a survey that will be sent to you. If you would please answer the survey, it will greatly help us at NCSL to determine how we can provide better information and better webinars in the future. So with that, I would like to say very much again, thank you for everyone who participated and have a great afternoon.